We are starting in 3, 2, 1. Please start, sir. We are live.
Hello, good evening, everyone. I would like to welcome you all for this webinar, Oncology Treatment Update 2022. For the welcome and introductory note, I would like to invite Dr. Manish Sharma, sir, Consultant Medical Oncologist, Rajiv Gandhi Cancer Institute, Delhi. Over to you, sir, for further proceedings.
Thank you so much. Good evening, everyone. And I really welcome you all. Thank you, all my colleagues and friends, seniors, for being here. And at the outset, I would like to thank AstraZeneca and Novartis for organizing this webinar. And we know that breast and lung cancers, they are the most common cancers amongst human beings nowadays. In the females, it is a breast cancer. Males and females, both, it is the lung cancer. And most of the newer innovations, they're happening across the world in lung and breast cancer. So it becomes imperative to discuss about the newer treatment paradigms that are coming daily and daily in these two cancers. And for discussing this, we have Dr. Praveen Jain, who is consultant medical oncology in Akash Institute. Then we have Dr. Rajat Bajaj, he is senior consultant in Fortis IOSPL in Noida. And we have Dr. Venkat Pradeep Babu. So he will be taking us through a panel discussion, and I welcome all my panelists and speakers here on today's evening. So I think Dr. Rajat is here. Can we start, Dr. Rajat? Dr. Rajat? So the first session is by Dr. Rajat Bajaj. He is senior consultant medical oncology in Fortis Hospital, Noida. We will be talking about the Crixana, role of Crixana in hormone positive metastatic CA breast. We will be discussing about the overall survival with the Crixana in hormone positive metastatic CA breast. Dr. Rajat, please, over to you. So I think Dr. Rajat will take another few minutes. He is stuck somewhere. So we'll wait for another 2 minutes for him to join.
Sir, Rajat sir is joining in 1 minute. Manish sir, Rajat sir has joined.
Hello. Yes, am I audible?
Yes. So first session is yours, and I would like to invite you here and welcome you here. Dr. Rajat is senior consultant medical oncology at Fortis IOSPL Noida, and he will be taking us through the consistently overall superior survival with Crixana. Over to you, Dr. Rajat.
Thank you. Good evening, everyone. I thank Dr. Manish, the organizers, for having me here. Thank you, Novartis. I'm happy that I am 1 minute early than my scheduled time of 7:05. So I will start now. So We all know that ribociclib, which is with the brand name of Crixana, has changed the way we used to look at treating metastatic ER positive breast cancer. So how has all this happened in the last 7 to 8 years is what we are going to talk about in the next 15 minutes or so. So consistently superior overall survival has been seen with Crixana. Next slide, please. Yeah, so Crixana is indicated for the treatment of either postmenopausal or premenopausal women. With postmenopausal, its combination is with AI, that is in the initial therapy. With postmenopausal women in the second line, its combination is with fulvestrant. Although the trial for fulvestrant also included first line patients, so FDA approval for first line in combination with fulvestrant is also there for Crixana. And in premenopausal women, which is the trial called Mona Lisa 7, the patients should have received along with AI and LHRH agonist therapy to make them postmenopausal. And in this trial also, there has been a superior benefit of adding Crixana with AI as compared to only AI. Next slide. So we will discuss what is the clinical evidence supporting the superior efficacy of Crixana, the review of literature which shows that there is an improved quality of life, and it will discuss what makes Crixana different from the other available CDK4/6 inhibitors in the market. Next slide. So in hormone receptor positive, HER2 negative advanced breast cancer, the first line patients have challenging journey, and what they expect from the treatment is living longer life, living well, that is the quality of life should be better, and living longer without chemotherapy. And all these three boxes, they are ticked very well with Crixana. Next slide. Next slide, please. Yeah, next slide, please. Can I have the next slide? Yeah, so Crixana has been studied in diverse patient populations, including a variety of patients in the first line setting. Next slide. So first of all, talking about the three trials that we are going to talk about: Mona Lisa 2, Mona Lisa 3, and Mona Lisa 7. Importantly, Mona Lisa 2 and 3 are in the postmenopausal patients, whereas 7 is in the premenopausal patients, pre or perimenopausal. Also, very important to understand that Mona Lisa 2 and Mona Lisa 7 are first line trials, whereas Mona Lisa 3 was actually designed to be a second line study post aromatase inhibitor. That is why the the Crixana partner was taken as fulvestrant, but there were about 50% patients in this trial which were first line as well. So that is why the Crixana plus fulvestrant Crixana is the only CDK4/6 inhibitor where it can be used in first line with fulvestrant. Next slide. So what is the difference in overall survival which has been reported with Crixana is what we are going to talk about. The longest overall reported survival is with Crixana only among all the CDK4/6 inhibitors that we have. Next slide, please. So achieving the longest reported median overall survival, we're talking about Mona Lisa 2 now. Next slide. So like I said, it is in the postmenopausal patients where the upfront patients of metastatic breast cancer, they were randomized ER positive HER2 negative patients. They were randomized to receive either Crixana plus AI or AI alone. Next slide, please. And then the endpoints were PFS, which is the primary endpoint, and the secondary endpoint was overall survival. If you look at this being the secondary endpoint, which is the overall survival, the overall survival with Crixana in this population is 63 months approximately, vis-a-vis 51 months on with the control arm, which is only aromatase inhibitor. So certainly a huge delta, a delta of say about 12 months in overall survival is certainly something that we can vouch for. And with a p-value being highly significant and a hazard ratio of 0.76. So long overall survival has been reported with Crixana in this population. Next slide. Also important to know that overall survival, which is considered the gold standard in endpoint in most of the clinical trials, as all of us will agree. The OS benefit was not only there in the initial years, but in fact, as the years pass by and we have the latest update of this Mona Lisa 2, where this follow-up period has been 6 years, the quantum of benefit between the experimental and the controlled arm has continued to increase. It is about 12% in when we talk about the follow-up period being 6 years, whereas it is about 5.7% in the 4-year follow-up. So the control arm has not done increasingly well at all, but Trixana has continued to be there and has continued to work well in terms of overall survival. Next slide. So a sustained benefit has been seen, and what is more reassuring is that when we look at the subsequent treatment, so subsequent treatment, approximately 35% patients in this trial received a CDK4/6 inhibitor after progression in the control arm, but still the overall survival has been met, and consistently so over the years. So the difference in overall survival certainly is achieved if we are giving Trixana along with aromatase inhibitor in the first line in the post-menopausal setting, is what has been very firmly bolstered by the Mona Lisa 2 study and the updated analysis where the overall survival has been seen. Next slide. Time to chemotherapy also has been delayed by over 4 years. If you look at the TTC, which was one of the secondary endpoints of this study, the TTC was 50 months versus 38 months experimental versus control arm. So this also is something which is a very important point that one as a clinician has to highlight to the patient. So this also was certainly met in this study. Next slide. And the PFS of 25 months, although this PFS is nearly the same as compared to other CDK4/6 inhibitors, but certainly not a bad PFS at all. 25 months without chemotherapy in the first line, any day one would take that. Next slide. Time to response, very important. So many a times we do discuss that if the patient is having a visceral crisis and hormone receptor positive, then should we resort to chemotherapy? Probably with this graph in mind, there can be a little debate on that, because time to response is just 8 weeks, as we can see in this graph. 8 weeks is about 6 to 8 weeks is the period when chemotherapy also starts to take its effect. So not a bad time to tumor response at all. And in times to come, we may have the use of CDK4/6 inhibitors in visceral crisis patients as well, is something that we still would need to see, although visceral crisis patients were not included in this study. Next slide. Yeah, rapid reduction in tumor size, we've seen that. Next slide, please. So Trixana, consistent superior overall survival. Now we are talking about the other two trials, which is Mona Lisa 3 and then Mona Lisa 7. Next slide, please. So it is the only CDK4/6 inhibitors which has received a ESMO MCBS score of 5. That is, it ticks the 5 boxes of the treatment, the patient estimated OS gain, efficacy score, and the improved quality of life. Next slide, please. So talking about Mona Lisa 3, next slide, was a trial where postmenopausal patients in the second line setting post AI were randomized to receive Trixana plus fulvestrant or fulvestrant alone. Like I said in the beginning, that about 40% patients in this trial were first line therapy as well. Next slide. And what was seen was that the PFS in this trial was also superior to the control arm in the experimental arm, and the PFS in the first line was to the tune of about 30 months, and in the second line it was to the tune of about 12 months. And both of them taken together, the PFS was about 12 months, and all this PFS was superior to what was seen in the control arm. If you look at the overall survival in the intention to treat also was superior. It was 53 months versus 41 months. Again, very reassuring to see the OS also being improved in the favor of Trixana. Next slide. In the long-term follow-up also in the first line, if we see, the OS has not been reached, whereas the OS for the control arm is about 50 months. Next slide. Even for liver metastasis patients, the OS was 36 months versus 24 months. So liver metastasis patients, one of the bad subgroup of patients, also was benefiting with a risk reduction in death of about 37%. So it can certainly be used in patients who have got visceral metastasis or liver metastasis. About 40% of the patients in this study were having visceral metastasis. Next slide. And the time to chemotherapy here also was delayed by 4 years, which is again a good thing for our patients. Next slide. So the quality of life definitely is preserved. The pain scores are reduced as early as 8 weeks, and there is delayed deterioration in the functioning scores. So like I said in the beginning, that it ticks all the boxes that we want for our patients. Next slide. Reduction in tumor size as early as 8 weeks, similar to what was seen in the Mona Lisa 2 study. Next slide. And the survival benefit, like every clinician would want to know that what is the subgroup analysis. In the forest plot, we see that in the subgroup analysis, patients who are having metastatic sites less than 3 or more than 3, if they are having a bone lesion, yes or no, or involvement of viscera or no, all of the subgroups, pre-planned subgroups, they benefited with the use of Crixana plus fulvestrant compared to only fulvestrant. Next slide, please. And now talking about Mona Lisa 7 in the premenopausal patients. Mona Lisa 7 is the first line study of Crixana plus AI versus AI. Next slide, please. With the primary endpoint being PFS and the secondary endpoint being overall survival. Next slide. So we see that these patients, also premenopausal patients by convention, are not supposed to do as well as postmenopausal in advanced breast cancer, but these patients also benefited a lot with the OS of nearly 60 months is something which is a whopping number. All of us will agree with that. And the delta of about 10 months, that is a difference in OS that it could make in premenopausal patients, is also something worth appreciating. Nearly a 5-year median OS has been achieved in Mona Lisa 7. Next slide. Superior overall survival in patients with liver metastasis as well. So like I was saying in Mona Lisa 3 also it was there, and Mona Lisa 7 also was no different. So we can be rest assured that even if the patient is having visceral mets, she is in safe hands if she is receiving ribociclib. Next slide. And same is the case with time to chemotherapy delay, which was the case with the previous 2 studies. Next slide, please. And the quality of life also is improved in favor of the experimental arm versus the control arm. Next slide. And reduction in tumor size as early as 8 weeks is seen, similar to what is seen in the first 2 trials. Next slide. Benefit of OS was seen across all the subgroups, whether the patient had visceral metastasis or not, whether the metastatic, to know that is the time to prior chemotherapy and the starting of this Crixana plus AI, or if it was more
I think we have the Rajat signal are not there. Somebody can call Rajat.
Yes, sir.
Hello, yes. Am I audible?
Yes, Dr. Rajat, yes.
Yeah, sorry, there was a connection error. So I think next slide, please. I think we have come to the I have discussed almost all the points. So in the end, I would like to say that all the 3 clinical trials taken together, and with the overall survival which has been seen in all the 3 trials, it is quite reassuring as a clinician that if we are offering Crixana in the appropriate lines to our patients along with the appropriate partner drug, our patients are going to achieve a good quality of life along with a good survival. So this is my submission, and with this I thank Novartis, I thank Dr. Manish and the organizers for having me here. Back to the organizers. Thank you.
Thank you, Dr. Rajat. It was indeed a very crisp presentation, and we all know the overall survival is consistent with Vixana, and I think it is the best overall survival that we are seeing with the CD4/6 inhibitors. So the floor is open for discussion. If we have any questions from Dr. Rajat, we can ask.
I also think that Dr. Manish, I also think that with Crixana there is less of financial burden also. So when we are talking about only the scientific evidence, we may not talk about financial burden, but in the clinics we have to talk about those issues as well. So I've seen that that part also plays a lot of importance in the patient's mind, and this also is one of the factors in favor of Crixana. Of course, there is no doubt that the scientific evidence is hugely in favor of Crixana, but the other real world thing also we should be discussing, and this is what I feel in my practice. What are your views on it?
Definitely, I think India is a price sensitive market, and you definitely need to have a drug which shows survival benefit along with the cheaper to the pockets of the patients. So, Dr. Rajat, I have a scientific question. So, what do you feel? How do your patients do who are in visceral crisis with this drug? So, are you using this drug in visceral crisis? Because there is some evidence to suggest that few of the patients in visceral crisis, they also respond well to the Crixana, number one. And number two, what about the CNS penetration of the drug? So, I think Novartis has come up with a retrospective data in which they suggest that the drug crosses the CNS blood-brain barrier, and almost it is equivalent to abemaciclib, although we don't have a prospective data associated with it.
Yeah, so 2 parts to your question. First question is that if I have a patient who is having a visceral crisis and the performance status is absolutely good, then I would not, as of now, would like to use a CDK4/6 inhibitor. I would like to go with chemotherapy. Although I do understand that there has been a rapid time to tumor response, but still, for the want of further data, and because most of these trials have excluded the visceral crisis patients, I would still like to go with chemo. But having said that, you also, I think, will agree that most of the patients in visceral crisis will have a poor performance status. So if the patient is having a poor performance status, then I have no inhibitions in using a CDK4/6 inhibitor, because those patients will certainly not be good candidates for chemotherapy. And by giving CDK4/6 inhibitors, I am pretty sure that we will not be doing disservice to our patients. That is the answer to part number one. Part number two is about the CNS penetration. So I am aware of this retrospective data that you're talking about, but still, because we don't have a randomized study, I may be able to use Crixana in patients who have asymptomatic brain mets with close monitoring. But if the patient is having symptomatic brain mets, or the site of brain mets is at sites which are the critical sites, then I would like to use radiation followed by Crixana.
Very rightly said. I think we have the next speaker with us, Dr. Praveen. If there are no further questions, we can invite Dr. Praveen here. So, Dr. Praveen is a senior consultant in Healthcare Institute, and we know him very well. He is PI and co-PI in multiple clinical trials. So his area of interest is mainly solid malignancies, including lung and breast cancer. The optimal management of EGFR mutant NSCLC. So we will be talking about various trials and drugs which we can use in this setting. Dr. Praveen, we welcome you here.
Thank you, Manish, and thank you, AstraZeneca, for giving me this opportunity. Uh, so the task given to me today is the optimal management of EGFR mutated non-small cell lung cancer patients, and we are talking about metastatic patients here. So to start the talk, so let us talk about the incidence and mortality of lung cancer. And we know that it is one of the most common cancer diagnosed worldwide. And as per the Globocan 2018, so it has got most amount of mortality attributed, which is to lung cancer. And if we see 11.6% of all lung cancers, so they are 11.6% of all cancers are lung cancers, and it contributes to 18.4% of all cancer related death. So in particularly EGFR mutated non-small cell lung cancer, metastatic non-small cell lung cancer. So we have lot of agents which are available, lot of strategies which are available. So we have option of targeted therapy only, EGFR directed targeted therapy only. So then we have the option of EGFR directed therapy along with VEGF monoclonal antibodies. Then we have strategy of using EGFR targeted therapies along with chemotherapy. So we do have a lot of strategies. So, but after getting so many of the drugs which are available to target this particular subset, so which drug to use? So this is the biggest question as of now. And I think everybody will agree that we should use the best drug in the first line, because the first chance is the best chance. After that, maybe the patient will not be able to take the drug in the subsequent line, or the performance status of the patient becomes worse, and they are not candidate for some other therapies. So now we will discuss about these aspects only in the presentation, and we will come to a conclusion. So which drug to be used in this subset? So we have first generation EGFR TKI like erlotinib, gefitinib. So they can be used as a single agent, or they can be used along with chemotherapy or VEGF directed therapy. Then second generation EGFR TKI like afatinib and dacomitinib, and the third generation TKI, which is osimertinib. So we will discuss all these agents one by one, and we will compare it with the best agent available, which is osimertinib. So as per the NCCN guidelines, so in EGFR mutated metastatic non-small cell lung cancer, so if the EGFR mutation is discovered prior to first line systemic therapy, so then the EGFR directed therapy is the first therapy of choice. And if the mutation is detected during the first line therapy with chemotherapy, then we have two options: either to switch from 1 second, please. 1 second. I will have to connect my charger because my battery is going low. So I'm very sorry. So, and if the systemic therapy has already started, so we have two options. One is to immediately switch to EGFR directed therapy, or the other is that we can continue with the chemotherapy, and as a maintenance strategy, we can use the EGFR directed therapies. So what is the difference between a first generation, second generation, and third generation EGFR TKI? We can see over here that these all agents, they inhibit EGFR mutations, but the mutations which are inhibited by first, second, and third generation TKI, they are different. So the first generation TKI most often they inhibit the del19 and L858R mutations, which are the drug sensitive mutations. The second generation TKI, apart from these sensitive mutations, they also block some of the uncommon mutations. But both of these categories of agents, first and second generation agent, doesn't have any activity on T790M mutation. So osimertinib has got a additional activity on the T790M mutation. Apart from that, if we see the reversibility, so first generation agents, they are reversible blockers, and second and third generation are the irreversible blocker. And if we see the very important point of blood-brain barrier penetration or CNS penetration, so it is minimal with the first and second generation TKI vis-a-vis significant CNS penetration with the third generation agents. So these are certain differences between these agents. Here we can see, so this is the osimertinib molecule, which is in the blue color. So it blocks the common mutations, exon del19 and L858R. It also blocks the T790M, and it has got a very high response rates in these subsets. But it has got a wild type EGFR sparing effect. So with this wild type EGFR sparing effect, so the side effects profile of osimertinib improves as compared to first generation and second generation TKI. It has got less diarrhea, less skin rashes. So it improves the quality of life when the third generation TKI is used because of this wild type EGFR sparing. So this is the first line trial of osimertinib in EGFR mutated non-small cell lung cancer. And it was a phase 3 double-blind randomized trial to assess the safety and efficacy of osimertinib vis-a-vis standard of care EGFR TKI, which was first generation TKI at that point when this trial was started. And this was the trial schema. The flora included those patients with metastatic non-small cell lung cancer or locally advanced unresectable non-small cell lung cancer with exon 19 deletion or L858R. That means they only included the common mutations, and they also included the stable CNS metastasis. So this is a point worth noticing, that they included CNS metastasis patient, and these patients were randomized in 1:1 fashion into osimertinib arm vis-a-vis standard of care EGFR TKI, which were first generation TKI at that point of time, and either gefitinib or erlotinib was given on the basis of physician's choice. And the primary endpoint of this trial was progression-free survival, and the secondary endpoint was overall response rate, duration of response, disease control rate, then the depth of response, and even overall survival. So here, the stratification factors were the type of mutation, exon 19 vis-a-vis L858R, and the race, Asian versus non-Asian. And if we see in this trial where the EGFR TKI standard of care were given, so these patients were eligible for crossover, and these patients on progression, if T790M was positive, so they were candidate for osimertinib, and they were given osimertinib in this subsequent line. So this was the initial PFS analysis, which was published in 2018 New England Journal of Medicine. And we can see over here the curves, the Kaplan-Meier curve separated early on, and they remained separated, and there was a huge gap between the curves. And if we see the median PFS, it was 18.9 months with the osimertinib vis-a-vis 10.2 months with the standard of care TKI. So there was a big gap of 8.5 to 8.6 months, and hazard ratio was 0.46, which suggested that there was 54% relative reduction in the risk of progression or death with osimertinib vis-a-vis comparator EGFR TKI. And if we see the subset analysis, we can see over here that almost all the subgroups, they had a good amount of benefit favoring osimertinib vis-a-vis EGFR TKI comparator. So this was the overall survival analysis, which was published in 2019, and it was presented in ESMO 2019. So we can see over here that the median overall survival with osimertinib was 38.6 months vis-a-vis 31.8 months with a comparator EGFR TKI, and the hazard ratio was 0.799 and p-value was 0.0462. And we have to see this, that a p-value of 0.0495 it was determined by O'Brien Fleming approach, and it was required to show the statistically significant improvement in overall survival. And moreover, if we see the Kaplan-Meier curves, so there was 6% OS benefit at 12 months timeline. There was almost 15% OS benefit at 24 months timeline, and there was almost 10% overall survival benefit at 3 years timeline. So the benefit of osimertinib was persistent even at 3 years, and now the later analysis we will see. So this graph is showing that at 36 months, 28% of those patients, they are still continuing taking osimertinib, vis-a-vis only 9% of the patients who are still on first generation EGFR TKI. So there is almost tripling of those patients who are continued on osimertinib. So these patients are those patients who will continue osimertinib for a longer period of time. So this again, time to first subsequent treatment, it is a very important endpoint. So in targeted therapies, whenever we start a patient on targeted therapy, there will be a proportion of patient who will be continuing the therapy beyond progression, maybe because they are asymptomatic or because some local therapy has been given to oligoprogressive disease. So this endpoint, this takes into account all these patients who were continued on targeted therapy beyond progression. And here we can see that osimertinib had a time to first subsequent treatment of 25.5 months, vis-a-vis 13.7 months with the comparator EGFR TKI. And the hazard ratio was 0.478 and p-value was 0.0001, so which was statistically significant. Again, another type of thing that here we can see the first generation TKI, they have a median PFS of approximately 10 to 13 months, second generation 11 to 14 months, and first time there is a EGFR TKI which has shown a median progression-free survival of more than 1.5 years, and which is so it's a cross-trial comparison. We do not have any comparison between a third generation and second generation TKI, and this is something which we all know, that osimertinib, it has got the best PFS as compared to other drugs. So here this is a summary of subset analysis of PFS and overall survival, and we can see in PFS analysis, most of the subset had almost equal benefit out of osimertinib vis-a-vis EGFR TKI first generation. But if we see overall survival, so numerically, if we see, so all the lines, they are on the side of osimertinib only. But yes, the benefit, the amount of benefit in all the subset, those differed slightly on the basis of what subset was there. So, but overall, if we look at it, so there was some benefit in overall survival also, which was achieved in all these subsets. So now we will take other generation TKI. So first generation TKI. So these are the Indian studies in first generation EGFR TKI, and they had a inclusion criteria which differed in most of these trials. There were some trial like this Patil et al. Who selected EGFR mutated non-small cell lung cancer. Then next trial, they included in a second line where EGFR mutational status was not known. And in third trial, they had selected on the basis of clinical features only. So all these trials have shown those with the EGFR mutation, those have shown a PFS of 8 to 10 months and overall survival of 18 to 20 months. And those patients who were where EGFR TKI was given on the basis of clinical features, so there the PFS was to the tune of 6 months and median overall survival of 12 to 14 months. So these were those trials when osimertinib was not available in the subsequent line. That is why the median overall survival in these trial are 18 to 20 months only. So if we see the second generation TKI, so there are two phase 3 trials which are available for dacomitinib and afatinib. So if we compare dacomitinib trial, which is Archer 1050 with the FLORA trial, so the trial schema of Archer 1050 was that they included the same population which was included in FLORA, except those patients with brain metastasis, they were not included in Archer 1050, and these patients were randomized in 1:1 fashion in dacomitinib 45 milligram once a day plus vis-a-vis gefitinib 250 milligram once a day. And again, the primary endpoint was PFS and the secondary endpoint was overall response rate and overall survival and duration of response and safety. So here the hierarchical design was chosen. So initially they had to see the PFS analysis, and if PFS analysis was statistically significantly better in dacomitinib arm, so next analysis which had to be done was the overall response rate. And if only overall response rate analysis is statistically better in dacomitinib, then only overall a formal overall survival analysis was supposed to be done. And FLORA trial schema we had already seen in the previous slides. So the inclusion and exclusion criteria. So Archer 1050 had included those patients with pre-existing brain metastasis, whereas the stable brain metastasis were included in the FLORA trial. And if we see the efficacy analysis, PFS over here, these are the Kaplan-Meier curves, and we can see, so the curves were hugging each other till the 6 months timeline, and 6 month was the point post 6 month was the point when the curve separated, and then after that they remain separated altogether. So what does this suggest? This suggests that there was some inherent resistance to dacomitinib. In the initial 6 months, there were few patients which were resistant to this, and probably because of that, the curve did not separate early on. And the median PFS was 14.7 months in dacomitinib arm vis-a-vis 9.2 months in the gefitinib arm. So if we see here in the FLORA analysis, the curve separated immediately and they remained separated throughout. And the median of PFS was 18.9 vis-a-vis 10.2. So these are cross-trial comparison, but we can see over here that the median PFS with dacomitinib was 14.7 months vis-a-vis 18.9 with the osimertinib. And this overall survival, as we discussed previously also, that this overall survival analysis, it was not a formal overall analysis, overall survival analysis, because overall response rates analysis was not statistically better in dacomitinib arm, and therefore because of the trial design, this formal analysis was not carried out. And here they had shown that numerically it was, the overall survival was better in dacomitinib arm vis-a-vis gefitinib, which was 34 months versus 26.8 months. But one thing which we cannot explain is the early the curve was in favor of first generation TKI in the initial 12 months, and later on there was the curves crossed and then the improvement with the dacomitinib was shown. So we are not able to explain why this phenomena had happened. Maybe there was, as seen in the PFS analysis also, that there were few patients which did not show any improvement with the dacomitinib. So there must be some proportion of patients which are resistant to dacomitinib inherently. So if we see the overall survival curve of FLORA trial, so it separated early on and it remained separated throughout. And at different timelines, the benefit was maintained with the osimertinib. And so this was Canadian consensus guidelines, which showed that Archer 1050 trial had a hierarchical stratified statistical design. And given that it did not meet significance in overall response rate, a p-value could not be given to overall survival analysis. And this was not a formal analysis which was done. So if we see the differences between the Archer 1050 study vis-a-vis FLORA study, so again, so the patient with brain metastasis, they were excluded out of dacomitinib trial. whereas the stable CNS metastases were taken in the FLORA study. The median PFS was 14.7 months with the decomatinib and 18.9 months with the osimertinib. The Kaplan-Meier curve separated after 6-month PFS analysis, and Kaplan-Meier curve of PFS separated immediately in the FLORA trial, and the hierarchical gatekeeping procedure was used, and that is why a formal comparison of overall response rate and overall survival was not significant in Archer 1050 trial. And one most important point with the decomitinib trial was that 66% of the patient on decomitinib, they needed some dose reduction, and 33% of the patient needed 2 dose reductions. And there were almost 27% serious adverse event, and 10% were the population which had died because of the adverse event. So if we see over here osimertinib, so there were only 3% dose reduction, and SAE were found in 4% of the population, and AE leading to death were only 2%, so which was significantly better in favor of osimertinib. So if we compare afatinib versus dacomitinib, so afatinib did not had any overall survival advantage in comparison to the first generation TKI. Archer 1050, numerically the overall survival was more, but it was not statistically significant. And if we see all 3 trials put together, so here in Lung 7, there was some separation of the curve at 12 months timeline, but it was not statistically significant. If we see here in Archer 1050, that the Kaplan-Meier curve separated at 6 months, and but the brain metastases were included in this trial. And if we see the FLORA trial, the curve separated immediately. It was statistically significant PFS and advantage, and even after the stable brain metastases were included in this trial. So now coming to a very, very pertinent question in EGFR mutated non-small cell lung cancer. So that is the patients with brain metastasis. And we can see here that osimertinib is the ideal agent for brain metastasis. Isolated CNS progression, it is a big problem in EGFR mutated non-small cell lung cancer. And whenever we use first generation TKI, so a good number of patients only progresses in brain, and we can prevent these brain progressions if we use an agent which is very, very penetrable into the CNS. This is a preclinical study where we are able to see that there is a lot of uptake of osimertinib in the brain. So it shows that osimertinib has got a very good CNS penetration. And if we see the analysis of both systemic and intracranial efficacy were done in FLORA, and however the Lux Lung 3 and 6 study, they did not the results of intracranial efficacy were not published, and dacomitinib Archer 1050 trial, they had excluded those with the brain metastasis. If we see the FLORA CNS analysis, so those patients who were having pre-existing brain metastasis, they had a median PFS of 15.2 months vis-a-vis 9.6 months in the comparator arm. And those patients who were not having any brain metastasis but who progressed in brain, so the median PFS was 19.1 months versus 10.9 months in the comparator arm. So this was the intracranial CNS PFS, which was again reported in the FLORA trial. So FLORA trial did a complete CNS analysis, and they had seen in all possible ways. So how the osimertinib is getting benefit in these patients who were having either pre-existing brain metastasis or who progressed in brain. So we can see over here that the median CNS PFS was not reached in osimertinib arm vis-a-vis 13.9 months with the first generation TKI. So the CNS PFS was again statistically significantly better in osimertinib versus the comparator arm. So this graph is showing that those patients who were having brain metastasis at the trial entry, so 19% of the patient with osimertinib, they had progressed in brain vis-a-vis 43% of those patients with the first generation TKI had a progression in brain. So if we see those patients who were not having any baseline brain metastasis, only 3% of the patients they progressed in brain with osimertinib, vis-a-vis 7%. There was almost double the progression as compared to the osimertinib. So this shows that osimertinib has very good activity in brain in both the scenarios where there is pre-existing brain metastasis, vis-a-vis those who progressed in brain. So this is the NCCN guideline which suggests that osimertinib is the preferred agent for EGFR mutated non-small cell lung cancer. So the tolerability profile of FLORA trial showed that there were only 15% of the patient that in which there was discontinuation of the drug because of the adverse events, vis-a-vis 19% with the first generation TKI. So it has got a very good tolerability profile, osimertinib. And if we see grade 3 side effects, so they were observed in 18% of osimertinib arm, vis-a-vis 29% with the EGFR first generation EGFR TKI arm. So the main side effects with the osimertinib were the diarrhea, rashes only, and here in gefitinib erlotinib arm also it was diarrhea, rashes, but the LFT derangement was more with the first generation TKI as compared to the second generation TKI, and the grade 3 or 4 side effect, if we see the rashes and acne, it was only 1% in osimertinib versus 7% with the first generation TKI. So the side effect profile of osimertinib is definitely better as compared to first generation TKI. So as per the safety analysis of Archer 1050, so I told you that 2/3 of the patient required 1 dose reduction, and 1/3 of the patient they required 2 dose reduction, and 10% of the patient they died on dacomitinib because of the adverse events. So now, so why do we think that it is important that patient receive osimertinib in the first line? So these are two kind of approaches. So one is the osimertinib in the first line, and second approach is the sequencing approach. So here, all the patient, they will get the benefit out of osimertinib, and the median PFS is 18.9 months, and after that chemo will be given. So again, there will be a PFS of 5 to 6 months. So vis-a-vis those patients who were started on first generation or second generation TKI, the initial PFS of 10.2 months. So there will be only minority of patient who will be a candidate for second line osimertinib on the basis of T790M. So those patients are only going to get benefit out of osimertinib, and rest of the patients, 50% patient, they will not be candidate for osimertinib. So this was another analysis, and we can see like if 10 patients are started on first generation or second generation TKI, almost 73 to 77% patient they will be candidate for at progressions. Almost 3/4 of the patient they will be candidate for T790M testing, and out of those, only 2/3 to 3/4 of the patient they will have some eligible tissue biopsy or a valid T790M result, and out of these 60% of the patients, only 50% will have a T790M positive status. So only 33% of the patient out of these 10 patients, they will be eligible for second line osimertinib. So why to give advantage only to these 30%? We can give the advantage to 100% of the patient, and we can get the best outcome if we are giving first generation osimertinib. So there was this geotag study which was very debatable, that sequential afatinib followed by osimertinib is having the best outcome, but there were a lot of negative things and a lot of bias was there in this particular analysis. So geotag initially, so first of all, it was a retrospective observational analysis, and it excluded those patients who were T790 negative and or who were not tested for this. So they excluded those patients who died on first line afatinib and or those who could not receive a second line therapy. So there was a big selection bias, and the bad patients, so who were not a candidate for osimertinib or who could not take osimertinib because of the poor PS and all, So they were excluded from this this analysis basically. So they had only selected the best, the cream of the EGFR mutated patients, and those patients had like the geotag population was having a 74% of del-19 vis-a-vis 58% in the FLORA trial. So these patients, we know that del-19, they have got a better prognosis as compared to L858R, and they have better drug sensitivity as compared to L858R. So this was again a selection bias was there. The geotag endpoints, the time to treatment failure cannot be compared to a PFS, and it includes treatment beyond disease progression, so which we discussed initially, and the OS was also exploratory. So taking all these points, it is not possible to draw conclusion about the relative benefit of sequential afatinib followed by osimertinib vis-a-vis first-line osimertinib, which was a phase 3 prospective trial. So it is very difficult to say that afatinib followed by osimertinib is the best strategy to use. I think the best strategy is to use a very, very tolerable drug in the first line, which has got the best efficacy and the best CNS tolerability. So to summarize, osimertinib demonstrated a clinically and statistically significant improvement in overall survival. The median OS benefit of greater than 3 years sets a new benchmark for osimertinib. And FLORA is the first time where an EGFR TKI has translated PFS into an OS benefit. And nearly 30% of the patient, they remained on osimertinib at 3-year timeline. And all patient subgroups showed a positive effect in favor of osimertinib. And the most important thing is the safety profile of osimertinib. It remained consistent with the previously reported data in it. It has got the best safety profile as compared to the first and second generation TKI. With this, I would like to conclude my talk. And if there are any questions, I think we can take up now during the discussion. Over to organizers. Thank you.
Thank you, Dr. Praveen. So it was a very elaborate talk on oral TKIs, how to sequence them, and what is the best treatment strategy ahead. I think with the availability of osimertinib, which has got such a good brain penetration, and we know that most of our patients, many of our patients, they will fail in brain. I think it makes sense to use osimertinib. So my 2-3 quick questions to you. So have you started using NGS panel, whole NGS panel for adenocarcinoma lung patients, or you are still sending single gene testing?
So now, because I have moved to Akash, so there the availability of NGS reports is not very early on. And if we see the EGFR, ALK and ROS testing also, like single gene based testing. So it takes around 10 days to 12 days time to get all these reports. And the NGS report we can get in 20 to 21 days time. So what I am doing right now is I'm sending NGS in all the patients. And I'm starting off with the first cycle of chemotherapy, and I'm not adding immunotherapy in these patients till the time the mutational profile is available to me.
I think that makes a very important sense, and we can conclude that since the tissue is an issue with all these lung cancers, and you need to have NGS so that you can profile your tumor. I think it makes a sense that you give a single agent chemotherapy or double agent chemotherapy, and then go ahead with the TKIs when the report comes. So what are your thoughts on lorlatinib plus ramucirumab combination? The combination has come up in L858R. Do you feel it has something to do in this adenocarcinoma lung patients?
So see, the thing is that till this time, there is no EGFR TKI plus VEGF directed trial has shown an overall survival advantage. So all these trials, they had PFS advantage, but this was not translated into a overall survival advantage. So the survival results of erlotinib plus ramucirumab is still available, awaited. So I think we will have to wait for the overall survival analysis to come. The other thing is the cost constraint. So if a patient is eligible for, if a patient is affordable for erlotinib plus ramucirumab, so then why not to go ahead with the osimertinib, which is a better tolerable. It doesn't have any injection. Patient doesn't have to come for injections every 3 weekly, and doesn't have this much of side effect which are there with the bevacizumab, this ramucirumab. So there are chances of bleeding, there are chances of proteinuria, wound healing, then so I think we tend to avoid all these side effects by using osimertinib in first line.
I think most importantly about the CNS penetration, which obviously the osimertinib has the edge. What are your thoughts on complex mutations or compound mutations or uncommon mutations?
So usually for the treatment part, so we categorize these compound mutation or so uncommon mutation, you can say uncommon mutation, into three parts. So one is the compound mutation where compound mutation where there are either EGFR plus EGFR mutation is there, or EGFR plus some other mutation is there, like ALK mutation or MET mutation. So one is the compound mutation. The other one is the drug sensitive mutation like G719X or S768I. So these are those mutation which are drug sensitive mutation. And the third one is the exon 20 insertion. So if we see the drug sensitive mutation, so their second generation TKI, afatinib and osimertinib both works. Then the second type of mutation comes compound mutation. So those compound mutation where EGFR, two type of EGFR mutation is there, and if T790M is a part of that, so osimertinib works better as compared to afatinib. And if we see the third type of mutation, which is the exon 20 insertion, so we have a molecule like amivantamab, which is coming up for this particular mutation, and it has shown very good result in a phase 2 trial, and phase 3 trial is still on with amivantamab.
I think, Dr. Praveen, the list of questions is long for you, but we are short of time. And we'll quickly go ahead to the next session. I will be presenting. Is my screen visible?
Yes, it is visible, Manish.
You ever? So thank you so much, Dr. Praveen, and we will take the session ahead from here. I will be discussing a newer paradigm in the treatment of resected EGFR mutant early lung cancer. Thank you, AstraZeneca, for making me part of this session. So 1 in 3 patients with non-small cell lung cancer, they present with a resectable disease. So we know that most of our patients, they will present in stage 3 or stage 4 disease, but still almost close to 35% patients, they will have a resectable disease. And the lung cancer is a leading cause of cancer related death. It accounts for more than 1.7 million deaths annually. As many as that which are breast, prostate, and colorectal combined. So it is a single most important cause of cancer related death. And it represents, NSCLC represents 85% of all the lung cancer, with the estimated 30% of the patients presenting with resectable disease at diagnosis. So this is a brief staging, something like staging. So stage 1B, it is localized early lung cancer, and the regional or locally advanced lung cancer, they are stage 2 and stage 3. So these are the outcomes in early stage NSCLC, and they need to be improved. So previously we just had surgery for early stage lung cancers and radiation. And then in 2005, we started using chemotherapy, which did not improve much of overall survival in these patients. Then few of the clinical trials, they tried oral TKIs in EGFR mutant lung cancers, but they all had a disease-free survival advantage, and none of them had overall survival advantage. So it is still not a standard practice to use EGFR TKI in early lung cancer after resection. But we will be going through a trial which can place osimertinib in this line of treatment. So surgery is the main primary stay of the treatment in NSCLC patients, and adjuvant cisplatin-based chemotherapy is recommended for the patients with resected stage 2 and stage 3A NSCLC, and selected patients with stage 1B who have high risk disease such as tumor size more than 4 centimeter or poorly differentiated histology. The results from the large randomized clinical trials and meta-analysis showed that 5-year overall survival for the patients who had adjuvant chemotherapy in early stage breast cancer, early stage NSCLC. The overall hazard ratio was in most of these trials is 0.89. So please remember this overall hazard ratio of 0.89. We will be discussing about this hazard ratio in the ADURA trial. And DFS, it also favored adjuvant chemotherapy. Here also, kindly remember the hazard ratio, it was 0.84 in the adjuvant chemotherapy arm. So overall, the disease recurrence or death following surgery or adjuvant chemotherapy remains high across the disease stages. And in stage 1B, the 5-year recurrences rate are around 45%. In stage 2, the 5-year recurrences are to the tune of 60%. And in stage 3, they are to the tune of 76%. So there is a huge need for improvement in these resected patients. So based on the limited number of this study, the prevalence of EGFR mutation, it appears to be similar across the disease stages. So if we know that most of the EGFR mutations, the highest percentage of EGFR mutations, they are found in the Asian population. And in our country also, the percentage of the EGFR mutations is to the tune of 25%, and few of the Asian countries, they have reported this percentage to be 40 to 50%. While the Caucasians, they have the mutations to the tune of 10 to 20%. So few of these studies, they have looked into the EGFR mutations in the early stage disease also, that is stage 1 to stage 3. And even in these stages, the EGFR mutation prevalence remains the same. So it varies somewhere between 30 to 50% in the Asian population to 19 to 40% in the European or US population. So if EGFR TKI were available in the resectable setting, a similar proportion of the patients may be able to get the benefit as compared to the advanced setting. So we'll be discussing here the role of ADURA trial, so the role of osimertinib in the ADURA trial, in which the adjuvant therapy in the stage 1B to stage 3A EGFR mutant patients was given after complete tumor resection. So this is a phase 3 double-blind study, and the patients selected here were those patients who had completely resected stage 1B, 2, or 3A NSCLC with or without adjuvant chemotherapy. So they should have good performance status, more than 18 years of age. Then the EGFR mutations was must in this population, and maximum interval between surgery and randomization is 10 weeks without adjuvant chemotherapy and 26 weeks if the adjuvant chemotherapy was given. So 10 weeks without adjuvant treatment and 26 weeks after adjuvant treatment. So the stratification, predefined stratification was by stage, EGFR mutant status, that is deletion 19 or L858R, and race. These patients, they were randomized to the osimertinib, to the 80 milligram once a day or placebo. And the treatment, it was continued for at least for 3 years. So planned treatment duration was 3 years, or it could be stopped if there is disease recurrence, this treatment completed, or discontinuation criteria. So the endpoint here were primarily the endpoint were disease-free interval by investigator assessment in stage 2 and stage 3A patients. And it was designed for superiority and the assumed DFS hazard ratio of 0.70. So following IMDC recommendation, the study it was unblinded early due to the efficacy. So not due to the futility, but it was unblinded due to the efficacy. And here in this meeting, they are reporting the unplanned interim analysis of the unblinding of this study. So these are the inclusion and exclusion criteria for ADURA trial. We have already discussed in the previous slide, primarily the non-squamous NSCLC post-operatively stage 1B to 3A and confirmed to have exon 19 deletion or L858R, and standard post-operative adjuvant chemotherapy was allowed, but it was not mandatory, and patients they had received 4 cycles of maximum chemotherapy. Complete surgical resection of the primary NSCLC and recovery from resection surgery and treatment following the surgery. And all of the patients, they were to have a baseline, and these were the exclusion criteria. If the patients they had pre or post-operative radiotherapy, pre-operative chemotherapy, EGFR TK if they have already taken, or if they would have been on the CYP3A4 inhibitors for in the last 3 weeks, and the time between the surgery and randomization not more than 10 weeks if the adjuvant treatment was not used, and 26 weeks if the adjuvant chemotherapy was used. Patients who have had only segmentectomy or veg resections, they were also excluded. The patient need to have the lobectomy. So this is the baseline characteristic of the patients. Most of the patients, they were female. The median age was around 64 years. And mainly the patients who were here were Asian population. So we can see here that the ratio of the Asian non-Asian population was 64 and 36 in the osimertinib and the placebo arm. Baseline MRI or CT scan of all the patients had to be done in this trial. And adjuvant chemotherapy, 60% of the patients they had received adjuvant chemotherapy and 40% they had not received any adjuvant. So these are the Kaplan-Meier curve for the predefined subset in this ADURA trial. Osimertinib it improved disease-free survival versus placebo in resected EGFR mutant NSCLC. So if we see here, the hazard ratio for the median disease-free survival, it is 0.17 in the in those patients who had received osimertinib. While if we remember that this hazard ratio with the adjuvant chemotherapy was 0.84, so such a huge difference between the hazard ratios if we are using adjuvant osimertinib or adjuvant chemotherapy for our patients. So median DFS has still not been reached in this primary population, but for placebo it is 19.6 months in the stage 2 or stage 3A, and in stage 1B, 2 or 3A it is 27.5 months. So there is 83% reduction in risk of disease recurrence or death with osimertinib here, and 80% here, hazard ratio being 0.17 and 0.20. So 2-year DFS was consistent for osimertinib arm across the disease stages, 1B, 2 or 3A. We can see here that 2-year disease-free survival was to the tune of 88% versus 71%, 91% versus 56%, and 88% versus 32% in the ADURA trial in the osimertinib arm. So stage 3 patients, they have most of the recurrences, and you can clearly see here that 88% of the patients they had disease-free survival at 2-year mark. And see the hazard ratio here. The hazard ratio is 0.39, 0.17, and 0.12 in the various stages of the disease. If we see the subset analysis of the disease recurrence or death according to the investigator assessment, there was not even a single subgroup in which there was no benefit of osimertinib adjuvant treatment. So male, female, or whatever the age may be, smoking history, Asian or non-Asian population, and EGFR mutant status, that is exon 19 deletion or L858R, the drug was working well all of them. So this is the early snapshot of overall survival in patients with stage 2 and 3A NSCLC adenocarcinoma. The median overall survival has still not been reported with osimertinib or placebo, but we see here at 2-year mark, almost the difference between the disease-free survival is approximately to be 7%, 93% in the overall survival, the 93% in the placebo arm and 100% in the osimertinib arm. Patients and investigators, they remain blinded to the treatment in order to facilitate the assessment of OS at maturity. So the data is still not mature, but you can clearly see here that there is 7% difference in the overall survival in stage 2 and stage 3A at 2 years. So these are few of the EGFR TKI trials in the adjuvant setting in EGFR mutant NSCLC. All of them, they had achieved disease-free survival, but not overall survival benefit has been demonstrated in these trials. So select study from erlotinib, radiant study using erlotinib in adjuvant setting, Ivan study using erlotinib in adjuvant setting, or adjuvant CTONG study using gefitinib. So all of these trials, they had shown disease-free survival benefit, most of them, but no significant overall survival benefit. But if you see here, in all these trials, the hazard ratio was to the tune of 0.62 or 0.73 and 0.56, like that. But if you see the hazard ratios in the ADURA trial, they were somewhere around 0.17 or 0.2 or 0.3. One of the important things to remember in the ADURA trial is the type of recurrences that were seen in the resected NSCLC patient. So sometimes the local recurrences, they are salvageable in NSCLC patient, but if the distant recurrences occur or the brain recurrences occur in NSCLC patients, the prognosis become extremely bad, and these kind of patients, they don't survive much. So local or loco-regional recurrence is associated with prolonged post-recurrent survival than distant recurrence. This is a fact that we know. And the preventing CNS recurrence is an area of unmet need in the NSCLC patients, EGFR mutant patients. So the CNS is a common site of distant recurrence among the patients with EGFR mutant NSCLC receiving EGFR TKI. And in adjuvant radiant study, 37% of the patients with EGFR mutant NSCLC treated with erlotinib had the brain recurrences, CNS recurrence. So in radiant study, there were 37% of the patients who had CNS recurrence even when they were kept on EGFR TKI. But osimertinib has been known to have a significant exposure in brain compared to the other TKI with good blood-brain barrier penetration. And in advanced NSCLC setting, first-line osimertinib, it has demonstrated consistent superior survival and 52% reduction in risk of CNS progression. So we can expect that this drug will have some overall survival advantage, and it will be a standard of care when the final overall survival matures. So important to know in this ADURA trial what were the type of disease recurrences in different patients. So when the data, it was unblinded, 11% of the patients in the osimertinib arm had recurrence, while 46% patients in the placebo arm, they had recurrence. If we see the type of recurrences, 36%, 38% of these 11% patients, they had a distant recurrence, while 62% patients, they had loco-regional recurrence in the osimertinib arm. While if we see the placebo arm, the 61% patients, they had distant recurrences. So just the opposite of what we are seeing in the osimertinib arm. And 39% patients, they had loco-regional recurrences. So these are the site of recurrences in these 11% patients who had recurrence when the data was unblinded, and 46% of the patients in which the placebo was given. So if you see just 1% patient, they had CNS recurrence in the osimertinib arm, while 10% patients they had CNS recurrence in the placebo arm. Similarly, we see the lung recurrences, the lymph nodal recurrences, they were less. The locoregional recurrences, they were more in osimertinib arm as compared to the placebo arm. 6%, 6 plus 3, 9% patients, they had locoregional recurrence, while 18 plus 14% plus 10% patients, they had the systemic recurrence in the placebo arm. So overall, 45 patients, they had CNS DFS events. And if we see the osimertinib, just 2% patients, they had CNS recurrence. So the CNS recurrence was seen in one patient, while one patient had died. And 11% of the patients in the placebo arm, they had CNS recurrence. This is CNS DFS in osimertinib versus placebo. So CNS DFS in placebo arm is 48. So median CNS DFS in placebo arm is 48.2 months, and osimertinib it has still not reached. So at 3 years mark, 98% patients in the osimertinib arm, they are CNS DFS free, while 82% patients in the placebo arm, they had CNS DFS free. So close to 16% patients, they had CNS recurrences there in this trial. This is statistically significant, and if you see the hazard ratio here, hazard ratio is 0.1. So these are a few of these adverse events associated with osimertinib. So whenever we are giving osimertinib for a longer duration of time, we expect fewer of the side effects to happen. And these side effects, they are manageable, but still 7% dose reductions they were seen, and 11% dose discontinuation were seen in this trial. So most of the patients, they had diarrhea, paronychia, dry skin, pruritus, cough, and stomatitis as the side effect of the drug. Few of the patients, they had nasopharyngitis and decreased appetite. So QT prolongation was reported in 7% of the patients who were on osimertinib and 1% of the patient in the placebo arm. So QT prolongation is one of the things which needs to be watched for. And 3% of the patients, they developed grade 1 or grade 2 interstitial lung disease while on the osimertinib. So we are discussing the post-operative chemotherapy use and the adjuvant osimertinib, whether the chemotherapy usage had some effect on the DFS or overall survival in these patients. Overall survival has still not been reported, but we will be discussing about disease-free survival. So we have a closer look on the overall patients who received adjuvant chemotherapy. So, most of the patients, they had received the adjuvant chemotherapy for a median duration of 4 cycles. It was consistent across the treatment arms. The major patients received platinum-based chemotherapy, mostly in the stage 2 or stage 3, 76% patients they had received adjuvant chemotherapy, and in stage 1B, 26% patients they had received adjuvant chemotherapy. So this is the disease-free survival in patients with or without adjuvant chemotherapy. So those patients who had received adjuvant chemotherapy, the disease-free survival was 89% at 2-year mark and 49% to the placebo arm. And if you can see here, the hazard ratio is consistently 0.16 here. And if we did not have, the patient did not have received adjuvant chemotherapy, still the drug, we can clearly see the difference between the DFS which we can achieve if we are not given adjuvant chemotherapy. So DFS in patients with or without adjuvant chemotherapy by disease stage, almost all the patients, they had advantage whether they had received adjuvant chemotherapy or whether they had not received adjuvant chemotherapy, and the hazard ratio
Dr. Manish, your voice is not audible.
Dr. Manish has disappeared and his voice has also disappeared. So I think someone from the organizer side, please contact Dr. Manish.
Sure, sir. We are just coordinating. Manish sir is rejoining.
वॉल्यूम तो कर वॉल्यूम है नहीं।
Hello.
Yes, Manish.
Acha, you can hear me, na? Can you share the screen? I think 3 or 4 slides they are left. So I've joined from a different device. So we had covered this. The next slide, please. Next slide. Next slide. Slide. Next. Yes. So when we are giving a drug for such a longer duration of time, we need to know the patient-reported outcomes also. We have seen that 7% dose reductions they were there in the adjuvant osimertinib treatment trial, and 11% patients they had permanent discontinuation. Next slide. So this is health-rated health survey SF36, in which the physical component summary was asked from the patient, and mental component summaries they were asked from the patient. In the physical component surgery survey, the physical functioning, role functioning, body pain, and general health status was asked, and in the mental component survey, vitality, social functioning, role functioning, and the mental health was assessed. So these were the 2 summary scores which were taken, and total 8 health domains they were used. The data, it was collected at the beginning, then week 12, then week 24, then week 24, and then subsequently. Next slide.
Dr. Manish, you have 2 more minutes to wind up.
Next slide. So if we see here, the overall, the compliance rates with SF36 health survey were high in more than 85%. And if we see the time to deterioration of physical and mental component summary, it was consistently the same across the osimertinib arm and the placebo arm. Next slide. So the adjuvant osimertinib is the first targeted agent in the global trial to show statistically significant and clinically meaningful improvement in DFS in patients with stage 1B, 2 and 3A EGFR mutant and SCLC. And overall, there was 80% reduction in the risk of disease recurrence or death with osimertinib. Osimertinib versus placebo, DFS rates at 2 years were 89% versus 52% respectively. And adjuvant osimertinib demonstrated a clinically meaningful CNS DFS compared with the placebo. The safety profile, it was consistent with the previously reported safety rate of osimertinib with mild TKI class effects reported. Next slide. Thank you so much for your patient listening. Thank you so much. So I think we are running short in time, and we can start with the panel discussion. We will take few of the discussion questions in the panel discussion by Dr. Pradeep Babu. I invite Dr. Pradeep Babu. He is a very dear friend and a colleague. He is currently a cancer
Ex-student.
oncologist at Assam Cancer Institute. Dr. Babu, are you here?
I am here, sir. Can you hear me?
Yes, please welcome.
Yeah.
You're looking very nice.
After Pushpa movie, everyone has changed the look.
Yes. Pushpa ke baad Babu looking very nice.
His shoulder is also looking drooped one side.
So I will adjust my shoulder.
So the Pushpa 2 movie will have a Venkat look. Now, so next time Pushpa 2, so there will be a mustache and there will be a shirt and everything.
Sir, here in Tezpur, there are a lot of army people actually. So it is army cantonment area where Air Force and you meet a lot of army people. So it's like that. I am trying to share my screen, but somehow the PowerPoint in read-only mode is not being seen. Yeah.
Reflection like should think of that because hypertension is the commonest side effect. Yes. So
Yeah. Can you see my screen, sir?
Yes, sir. We
Yes,
can see your screen.
it is clear.
So good evening, all of you. So it's very nice to meet all the colleagues and seniors from Rajiv Gandhi whenever we have such CMEs. And today, whenever we discuss about cancer, particularly as we are reaching about to have World Cancer Day in 2 days, and whenever we discuss about cancer, two cancers definitely stand out, and we are discussing about those two cancers today: breast cancer and lung cancer. One of the cancers like breast cancer, they are detected in relatively in younger early stages because of the superficiality of the disease of the superficial tissue, whereas in lung cancer majority of the patients they are diagnosed in metastatic stage. So today we are dealing with those lesser number of patients who are diagnosed in early stage lung cancer, at least pertaining to India. So let us take the opinions and thoughts of our young oncologists as well as the senior oncologists who are present with us today in this meeting. So for this panel discussion, we have our young colleagues, Dr. Satyanarayan, Dr. Arpit Jain, Dr. Pallavi. Are you there?
Yes, sir.
Yes,
Good
sir.
evening,
Good
sir.
evening, sir.
Good evening.
Yes, sir.
And we have senior oncologists with us, Dr. Pankaj, Dr. Rajat, Dr. Praveen, and Dr. Priyanshu and Dr. Kshitij. So I think
I am intermediate oncologist, sir.
So,
I'm not senior.
depending
I'm
upon
an oncologist only.
nice to see you all.
Is he not in the young oncologist?
Young, but in the category of hierarchy, I would say I'm intermediate.
अरे ऐसा कुछ नहीं, उसमें यंग फीमेल्स होंगी या ओल्ड फीमेल्स होंगी, उस पे वो इंटरमीडिएट रहता है.
Yeah,
सर है
but
एक,
our case
एक
is
स्पेशल
about
ग्रुप है सर, हम
generally.
जैसों के लिए एक इंटरमीडिएट है सर.
ठीक है.
Yeah, yeah.
अबे तुम कम टू द पॉइंट. हाँ
Yeah.
वेंकट,
Yes,
कंटिन्यू.
sir. So our case is about a elderly gentleman who is a retired colonel who is in, surprisingly he is a non-smoker, presented with a mild cough. So in the army base hospital, chest X-ray was done, which showed a small lesion. And in view of the suspicion, even though he is not smoking, he is referred to the higher center where CT chest was done. But as he is retired, instead of going to the to proper channel, he went to a private hospital where Dr. Priyanshu is practicing, and PET CT was done. So within PET CT, a small lesion is seen in the left apical lobe. So now I want to ask Satyanarayan, Dr. Satyanarayan,
Yes, sir.
if you can see the small lesion in the apical lobe, left apical lobe here. So whenever a patient comes with a X-ray or CT scan showing a small lesion, let's say it is 3 to 2 centimeters. So what are the features in CT scan based on which you suspect and think in terms of cancer? Because you know majority of the SOLs, they need not be cancers, particularly non-smokers. So what are your thoughts on when you see such lesion in OPD? What are the features that will make you to suggest further investigation pertaining to cancer?
Sir, first I will see that whether the lesion is peripherally located or central located.
Okay.
So along with that, the as size is 3 into 2 centimeter. It is round in shape, and sir, only single.
Yeah, single lesion.
So
Your point well taken. Whenever there is a suspicion, a significant size is the factor which you are mentioning. Dr. Arpit and Dr. Pallavi, would you like to add any more points to what already Dr. Satyanarayan has alluded to regarding the characteristics of lesion, which will you on which you suspect the cancer when you see a CT scan of the patient? Dr. Arpit?
Yes, sir. Sir,
Yeah.
we can discriminate it with the benign lesions, like if it is not having the fatty attenuation and the calcification. So these are the peculiar finding of a benign lesion. And then the we can follow the previous scan also. If the doubling time is matching with the if it is progressed by more than 2 millimeter in last 2 years, then it is there in the high likelihood of the malignancy category.
Yeah, so that is really important point whenever patient is having a serial scans, and when you see a growing lesion on with a significant proportion per year, as you said, so definitely that is one of the indicator of malignancy. Dr. Pallavi, do you want to add any more features on which you suspect malignancy when you see a single lesion in CT scan?
Sir, if it is encasing the vessels or it is infiltrating the mediastinum, more likely to be a malignant.
Yeah, but here it is very much independent of the mediastinum. It is in the
Yes.
lung parenchyma. So your points well taken. The invasiveness whenever it is there. So putting together all the points told by you three guys. So any lesion which is of significant size, particularly when it is greater than 1.5 centimeters, and in a CT scan when you see the speculated margin, and a lesion that is growing in size. So all these, and whenever you see a ground glass lesion with a solid component in it, so all these factors they point out towards towards malignancy, which will force us to evaluate in the lines of malignancy, particularly when they present to us.
Dr.
So,
Pradeep, I think any lesion which is more than 1 centimeter in size and having significant solid component, not cystic component.
Yeah.
Your voice is
It needs
echoing.
to be
Manish,
evaluated.
voice is echoing.
I think very important
yeah.
that those patients, those scans which are showing a mass of more than 1 centimeter, they definitely warrant some sort of evaluation, either in form of biopsy, or if a mass is unequivocally
appearing to be malignant on imaging, then probably these are those patients who can directly proceed with the surgery, and at the same time mediastinal evaluation can be done in these patients.
Yes, sir. So that's really important point what we have heard just from Dr. Pevin. It's so these are the conditions where we can directly proceed with the surgery and we can do the intraoperative evaluation of the mediastinal nodes for the exact staging. Point well taken, sir. So for this patient, because PET-CT were done and it was decided to do the biopsy. So biopsy was done and PET-CT is showing only the single lesion in the left apical lobe with a very few subcentimeter prevascular lymph nodes, which are looking like a non-specific nature in terms of FDG, FDT. There are no other lesions anywhere in the body. And the biopsy was done, CT-guided biopsy and adenocarcinoma lung. Now, because lung CT-guided lung biopsy is something which is challenging, particularly in the places where I am practicing in the peripheral settings. And it is a routine procedure in apical institute like Rajiv Gandhi or AIMS or in other institutions, academic institutions. So now I want to ask Dr. Pankaj sir, so what is the incidence of pneumothorax when you ask a patient to undergo CT-guided lung biopsy? So out of, let's say, 20 or 100 cases, what is the percentage you see the incidence of pneumothorax when done by a interventional radiologist?
So that's a good question because all these procedures come with a risk, especially so the pneumothorax. And to best of my understanding, pneumothorax does happen in 8 to 10% of cases, but in most of them that is subtle. So most of the times even the radiologist won't even inform you that a mild pneumothorax has happened. So the clinically significant pneumothorax in which the patient might be symptomatic or you do want to have some intervention may be just only 3 to 4%. Rest 4 to 6% would be very small pneumothoraxes which are not clinically relevant.
Yes, sir. Thank you for that. Rajat sir, have you faced any patients with severe complications secondary to lung biopsy? Rajat sir, are you there? Okay. Let us take the opinion of Dr. Priyanshu.
Yes, sir. I had one patient of actually breast cancer with lung metastasis. So we had a very, she was around 55 or so. During lung biopsy, she had a major complication at the because the biopsy needle actually punctured through the bronchus, and she had a lot of bleeding and had to be intubated. She somehow survived. So there are some patients, although that was, we had weekly probably 15-20 biopsies going on in names, and out of the 3-year residency, I just saw one severe case. So it is the finite possibility is there, but in experience had and careful selection of the patient, I think so it can be minimized,
Yeah.
but not removed in total.
Yeah. So thank you, Priyanshu. So Dr. Shitij, so how do you like to proceed in this case? Because this patient has underwent, CT scan, PET-CT, biopsy. Now we have a 67 years old gentleman. So how do you want to proceed? Dr. Shitij, are you there? Dr. Shitij Domadia.
Oh, yes. Yes.
Yeah. Yeah.
Good evening, everyone.
Good evening. Hi.
So has a MRI brain been done?
No. That is one of the next question. Like, do you want to proceed? What are the other imaging tests along with the PET-CT you want to do?
So yes, in early stages, before proceeding to any operative procedure, I would definitely like to screen for brain. I would like to see. I would like to definitely see brain status by MRI.
Okay.
And obviously, the mediastinal evaluation has to be done.
Yes.
Mediastinal evaluation along with an MRI.
Okay. So if you want to do mediastinal evaluation, what are the procedures? And particularly in this case with a lesion that is distinctly separate from the mediastinum, looking like a 3 to 2 centimeter lesion, let's say, on a CT scan. So what is the procedure you would like to do in your setup? for mediastinal evaluation?
So if I'm getting a central mass which is infiltrating the mediastinum, I will consider it to be as mediastinal involvement is which is positive. So if I'm getting a peripheral lesion which is about 1-2 centimeter, and if the mediastinum is normal, then it is fine. But in rest of the cases, I need to see the mediastinum.
Yeah, all right. So just like Dr. Praveen has clearly pointed out, so we can directly go for surgery and we can do mediastinal evaluation during surgery also. And doing the preoperative mediastinal evaluation is one of the options. So NCCN exactly points out the same, that we need to do whenever we are planning for surgery particularly, we need to do pulmonary function tests, which are, there are several types of pulmonary function tests evaluated by surgeons to see the fitness of the patient post lobectomy, and bronchoscopy during surgery, mediastinal lymph node evaluation or prior to that, and FDG PET CT, definitely to rule out any metastasis before going for a definite surgery. And one of the things that is mentioned is beyond stage 1B, because it is stage 1A where there is no necessary for the brain scan as per NCCN, and beyond stage 1B, all patients should be done MRI of the brain.
So if it is a very early stage disease, something like 1A, usually NCCN doesn't recommend doing a MRI brain, but practically speaking, we are doing MRI brain for all of our patients. Even if you see this Adura trial, in which the early stage cancer patients, they were taken, even in stage 1A, 1B, all the patients, they had done MRI brain. So practically speaking, we are doing we are evaluating brain for all of our patients.
Yes, sir, that makes sense actually, because although 1A, the patients to pick up in stage 1A is relatively rare, and beyond 1B also, many of the institutions routinely do not do the brain scan. But it is definitely good to do a scan when you are definitely going for a costly treatments like surgery or even CTRT. The reason being, although my experience is very small, I have seen one patient who is quite well educated and who is wife of some a prominent person from a pharma industry, and she is determined to be stage 2. She is determined to go undergo CTRT, and while undergoing CTRT, she had a headache, and MRI brain was CT was done, which is normal. MRI was done. There was a cerebellar lesion, and she is later retrospectively evaluated for the EGFR mutation, and that is a hell of task to explain to them that it may be misdone planning CT also, or even normal CT cerebellar lesions may not be seen, all these things. So definitely it makes sense to do MRI brain.
No, but Venkat, why in this subset MRI brain was omitted was because in those peripheral lesion with less than 2 centimeter in size, so the N1 lymph nodal involvement is to the tune of less than 10%.
Yes, sir.
And the brain involvement is less than 1 to 2%. So that is why, to reduce the cost of the therapy and to reduce the other logistic issues, so MRI brain was omitted in this particular subset.
Yes, sir.
All those patients were
I
either
think
central tumor or more than 2 centimeter tumor. So those are those tumor where the N1 nodal involvement means the hilar nodal involvement is increased. So they increase. So those are those candidates where the chances of brain metastasis or some distant metastasis increases significantly as compared to peripheral lesion. I think what we are doing is we are getting MRI brain done in all the patients, because most of the times these patients they land up to us in a OPD of surgeon, and they decide whether to go ahead with MRI brain or not. So at later time we usually do not get it done.
Yes, sir. Yes, sir. Point very well taken, sir. So obviously the whether to do a particular metastatic evaluation or not is definitely decided by the incidence of metastasis seen in particular stage. That's why in a very early breast cancer where we'll do very little evaluation, including only CBC or sometimes, and ranging from local advanced breast cancer where we need to do bone scan or even PET CT. So it is depending upon the number of what is the chance of incidence of metastasis pertaining to that stage. So point very well taken, sir. So this patient who underwent surgery. So this is the histopathology report. and it is showing a 2.9 into 2.5 into 2 centimeters single tumor, which is invasive adenocarcinoma by histology, which is SNR predominant, and it has a micropapillary component of 25 to 30%. It is moderately differentiated. So the final pathological stage is PT2 PN1. So Dr. Satyanarayan, whenever you see you encounter a patient with such a report, and the patient is coming with a histopathology report after surgery, what are the points you wanting to see within the report so that to decide upon the adjuvant therapy?
Sir, regarding adjuvant therapy, radiation therapy, I will see the margin status of the resected section and the involvement of the node. So if it is margin positive and N2 stage of node is involved, so in that cases, I will consider, especially for margin positive, I will consider, sir, adjuvant radiation.
Yeah. So as of now, I think the main indication of post-operative radiotherapy is margin positive. Manish sir, do you have any more comments on this?
I think I agree with Satyanarayan, and we would like to see all these parameters, nodal involvement, then dealing with one A disease, what is the size of the tumor, whether there are some high risk features present or not. Otherwise, yes.
Yeah, thank you. So Dr. Pallavi, Dr. Satyanarayan point about adjuvant radiotherapy. Is there any other type of adjuvant therapy you want to give in this patient, considering the factors of size, differentiation, and other things which you see in the report? Dr. Arpit Jain?
Yes, sir. It seems to be a stage 2B disease. So we'll go for the adjuvant chemotherapy for 4 cycles, followed by we'll do the EGFR testing, and accordingly we will proceed.
So why do you want to do EGFR test in this report? Which factor provocates you to do the EGFR report?
So just in line with the ADORA trial of inclusion criteria of the ADORA trial, where they enroll the 1B to 3A disease. So it
because
is
of adenocarcinoma, basically. Do you do
Yes, sir.
In other types of histologies also, EGFR post-surgery?
So we can do it in the very young non-smokers squamous cell carcinoma patients also.
Yeah.
Or in the adenosquamous
that is the principle mainly applicable for metastatic carcinoma as of now. Yes, as you rightly pointed out, adenocarcinoma, and we need to do EGFR mutation also. And what is the chemotherapy you want to give in this patient?
So 4 cycles of pemetrexed plus cisplatin-based chemotherapy.
Yeah.
So we can also discuss for the role of vinorelbine plus cisplatin, but we'll prefer for the pemetrexed plus cisplatin.
Yeah. So Dr. Priyanshu, we know that because of availability of osimertinib, we are doing EGFR. Do you want to do Alcon PD-L1 also in early lung cancer? Are you practicing it, or do you want to do in the future?
So recently, atezolizumab has been approved for adjuvant in adjuvant setting in PD-L1 positive. So I would like to do that, but and in future probably we'll be having adjuvant ALK, probably lorlatinib or such drugs also. So currently, I'm doing EGFR and PD-L1 only.
Okay. Dr. Kshitij, out of all the 100 patients, how many patients you see undergo surgery, and what are the factors that may prevent the patient to undergo surgery even when they are fit due to the clinical stage? What are the other factors that prevent them from undergoing surgery?
Hello.
Yeah,
Sir, your
Kshitij.
voice was getting interrupted. Sorry, sir, I didn't get the entire question.
Yeah. So
Yes.
out of 100 patients you see in a early lung cancer, why some of the patients defer the surgery, are unable to undergo surgery? What are the possible reasons in your practice?
So mainly it is the stage.
Yeah, early stage. Let's say they are the stage is such that they are fit for they need surgery, but if at all they are not undergoing surgery, what are the main reasons?
their performance status,
Yeah.
their age, their comorbids, their pulmonary function test, all these things should be looked upon.
Okay. Medical inoperability. All right.
Yes, medical inoperability. Yes, sir. Yes, sir.
Yeah. I take this question. I would like to ask Dr. Praveen sir. What is the role of neoadjuvant therapy in early NSCLC as far as EGFR positivity is concerned? So, are you hopeful that because of the excellent results in the adjuvant setting, it will pave its way into the neoadjuvant therapy? Because normally the drug cycle from the metastatic to the adjuvant to the neoadjuvant, that is the normal way of any drug. Now we have osimertinib from the metastatic to the adjuvant setting. Do you think that it will pave its way into the early neoadjuvant setting also, sir?
So I totally agree. So there is a trial by the name Laura which is going on, and so it's in I think Laura, no, Neo
Neo-Adora. Yeah.
something like that.
Yes.
So there is a trial going on, but there is one particular concern about this, because these drugs most of the times they are static drugs. So if you are using it in a early stage lung disease, and if there is good resist response, so while doing a surgery or while giving radiotherapy to that particular lesion, so what will be the volume size of radiotherapy? So these concerns are still there until the time the result of this particular trial is available. So it will be very difficult to comment on the role of EGFR targeted or some other targeted therapy in the neoadjuvant setting. But however, the role of chemotherapy is definitely there in case uh, the lesion is so in case there is N2 nodal involvement, and where the surgeon feels that yes, post neoadjuvant chemotherapy there will be a role of surgery.
Yes, sir. So it is very interesting trial, like you said, sir, and there are definitely concerns because we may be using up the very potential surgery or potential drug, that to static drug in the neoadjuvant setting, and we may end up with nothing unless we have more and more discoveries in this setting. So
And
coming to
moreover,
this, yes.
Venkat, there is also one more concern. Let's see the resectability status of a mass in lung cancer. So it is done in the upfront setting. So once a mass is unresectable, that is going to be unresectable throughout.
Yes, sir.
So if a mass is not resectable, then there is no point of giving neoadjuvant chemotherapy, neoadjuvant this targeted therapy. And there will be 20 to 25% of the patient who will be inherently resistant to this particular targeted therapy, and you might lose the window of opportunity of giving a definitive therapy, may it be CTRT, may it be surgery, in these particular patients.
Yes, sir. So that is really important point, because the extent of disease, what we see radiologically in CT scan or PET CT scan, is not only the extent of disease, it's not the real extent of disease. There are several factors. There are circulating tumor cells and several latent disease. That's why when we discuss about early stage lung cancer, this is the reason why I am showing this slide, because when we say start with stage 1B, where we say that we are starting with a curative intent, but when we see how many patients are alive by year 5, there nearly 33% of patients we are losing for stage 1B lung cancer, even with the adjuvant chemotherapy, which means only 2/3 of patients are alive by year 5, even in such a early stage, which Dr. Praveen has clearly pointed out. When we are not selecting the patients clearly, as once the patient is unresectable, he is unresectable for throughout. In the same way, when you see stage 2, nearly half of the patients we are losing by 5 years, and stage 3, 61 patients. In the same way, in this slide, I want to focus on this blue shade, where 3% of patients, they are being benefited with adjuvant chemotherapy 4 cycles in stage 1B. And as you move on from stage 1B to 2 and 3, the number of patients getting benefit from chemotherapy drastically increases. Nearly 1 in every 10 patients is being saved due to chemotherapy. In the same way, as Dr. Manish has clearly shown the benefit of adjuvant osimertinib in those patients who are receiving adjuvant chemotherapy, also in those patients who are not receiving adjuvant chemotherapy also, both are being equally benefited by osimertinib. And there is no doubt when we see these curves where we hardly see in the history of medical oncology the DFS benefit getting so much with osimertinib. But as just we can see here the hazard ratios 0.17 and 0.12, which means nearly 83% and 80% of patients, they are being prevented from any event of progression or death related when we are using osimertinib in such patients. However, when we see the Indian setting, we cannot undermine the effects of Radiant as well as CTON. However, these are Chinese trials. We may need our own trials to see whether in a patients who may not be affordable for osimertinib, whether we can use these drugs at least to prevent some more deaths, to prevent some more morbidity in terms of relapse. But as of now, we have the golden molecule called osimertinib to use it. And whenever feasible and whenever the finances allow, we should use osimertinib, particularly to prevent the CNS recurrences, which is the most dreaded complication. Once which happens, both the physician and patients are equally, depressed because of the poor prognosis of CNS metastasis. So at the end of this session, if we ask, is ADARA practice changing, or do we need to wait for OS benefit? If we really wait for OS benefit, we may really not see any benefit in this trial in terms of OS, because the patient, as Dr. Manish rightly pointed out, the trial has been allowed for the crossover, and so we cannot really see whether real OS benefit will be seen at the end. But as of now, osimertinib is recommended in all the adjuvant settings from stage 1B to stage 3B, where there is incremental benefit in terms of decreased relapse in CNS and probably OS benefit. Thank you and good night.
Thank you, Venkat.
Thank you.
Thank you, Manish.
Thank you, Dr. Pradeep. That was an excellent panel discussion. Thank you, Dr. Praveen. Thank you, Dr. Rajat, Dr. Satyanarayan, Dr. Pallavi, Dr. Arpit for being part of this meeting. And thank you, Dr. Pankaj and Dr. Kshitish, Dr. Priyanshu for attending this panel discussion at such a short notice. And I think ADURA is practice changing. As clearly seen in the earlier trials, the most of the recurrences, they were distant recurrences and CNS recurrences with either if you are using adjuvant oral TKI other than the osimertinib. But if you are using osimertinib, you are preventing CNS recurrences and distant recurrences, which are mainly leading to the death. I think this is a practice changing trial, and I thank Novartis, I thank AstraZeneca for allowing us this session. Thank you so much. Thank you so much. Good night.
Thank you.
Thank you,
Good
sir.
night. Good
Thank you. Good night.
Thank you. Good night.
Thank you, Satish.